should take off the mask, otherwise I'm afraid you cannot hear me clearly.
Yes, please.
Thank you. So it's Dana. Hi. It's Dana, your host today. I am a radiologist from the Peking Union Medical College Hospital, and I am the Vice President of the Youth Committee of the Chinese Society of Radiology. It is my great honor to host this international exchange program today. From the beginning of this year, we all know that we began to face a common crisis worldwide. The COVID-19 virus broke out. After months of fighting, China has achieved a great accomplishment and take the breakout under control. Although we have several cases every day now still, but I believe the breakout is already under control for real. Although the people are still suffering the crisis all over the world, some of the countries also get their primary success for the fighting with the virus as well, in Asia, in Europe, and also in America. Hence, under the lead of Professor Zheng Yujin, the chairman of the Chinese Society of Radiology has initiated this exchange program for 5 times. So today is the sixth exchange program all over the world. We actually launched this program aimed to share of our experiences through the fight with the virus and to help our friends, our colleagues around the world. This program is exclusively sponsored by Bayer Healthcare and Ultravist marketing team. We should also deeply grateful for their contributions and their help and their engagement. Without further ado, I would like to pass the microphone to our chair today, Professor Zheng Yujin. He is the initiator of this international program. He is the president of the Chinese Society of Radiology. He is also a good friend of Professor Wellington. He is also the president-elect of the Chinese Medical Doctor Association, and also the honorary membership of various international societies, including the RSNA, the ESR, the DRG, and the Japanese Society of Radiology, and so on. So now let's welcome Professor Jin to open this webinar meeting.
Okay. Hello, my dear Professor Wellington, Professor Terry, Professor Ho, Professor Chen, and Dana, and every colleagues. Good afternoon. So first, I'd like to thank very much about our friend coming here, and also thanks a lot about biopharmaceutical to organize this meeting in the online. So in the period of a very special time, we have to face-to-face online. I think Professor Wellington, we meet each other in the last RSNA. So we missed the face-to-face in the ECR. I don't know in the future which time we can meet each other in the face-to-face. So I think in this time, the COVID-19 is coming very suddenly. It's so from the beginning of this year, actually China is faced to this virus a little bit earlier, but actually under the control of our government and our doctors. So we use almost 3 months more and almost the control in the preliminary. So we get some preliminary experience. Our society is the Chinese Society of Radiology. We did some job for making some like the consensus and the recommendation. So our members, including Dana and other younger doctors, they translated them to English. So if you are interested for that, we'd like to send to you or through the via colleagues to your side. I hope maybe they can have some helpful for you. And if you have any question, maybe we can answer online or somewhere. Of course, is in this time we started some experience in the radiology side because we use CT scan. It's very beginning we can find out some lesions, so it's very helpful for the clinician. So maybe Professor Ho or Professor Chen, they have some experience to introduce to our friends. If you need some helpful or some assistance, just let me know. So finally, I just like to say is stay strong, our Russia friend, and stay strong, all of people in the world. Thank you very much.
Thank you, Professor Jin, for your speech. And I think you're right. We all are facing this problem. And I think Russia and China, we are, it's very, I think this is very precious time and experience for both of us. And so it is also our pleasure to see Professor Wellington here. And we all know that he is one of the most famous radiologists in Russia, and he is also our old friend. Well, and so now we'd like to invite Professor Wellington to, he is the president of the Russia Society of Radiology. And so now let's welcome Professor Wellington to give us the speech. Thank you.
Thank you. Thank you very much. Thank you very much, my dear friends. I'm very grateful to Chinese Society of Radiology and Professor Jin in particular, because we know that your country is ahead of any other country in the world fighting with this problem. And your work as a radiologist, as other medical specialists from China, your publications, all your scientific research and publications, they were of great help for all of us to be better prepared for this pandemic. And okay, as Professor Jin said, we are looking forward to real face-to-face meeting. We are sitting face-to-face, but it's a virtual meeting. So, but I hope there's still a very little hope that RSNA will be a real meeting still. They're not put it in the online format, so we are still hoping for it. Yes, but we have a lot of talks, and in order not to take your time, I will start with my talk, and my talk is about thromboembolic complications of in COVID patients as a challenge to diagnostic radiology. I'm not going to trouble you with statistics, but I guess you know that unfortunately Russia is country number 2. Yes, do you hear me? Sorry.
Hi, Wellington. Sorry, I think your presentation will be about half an hour later. And so
sorry,
now it is your opening speech actually, and so.
So sorry. So it was a misunderstanding.
Sorry to bother you, but.
No, it's okay. So please continue according to the program, because I saw that you changed the schedule. Sorry.
No.
Sorry. Please take the screen.
No, but thank you very much for your all your words and your sentences. I think you are exactly right. And actually we are also looking forward to the coming RSNA. We hope that we can meet at Chicago again, and but I think we need to wait for something like the vaccine or something. because although we're not sure whether the temperature is a reason or not, but still, you know, in the winter, autumn and winter, maybe the virus will come back again. And, so let's wait and see. Okay. Thank you, Wellington. So actually today we have another well-known expert from Russia side, who is Professor Igor Torin. Sorry, Professor Torin, I don't know whether my pronunciation is right or not, but it is really our great pleasure to have you here and to know more Russia radiologists through this program. And so now let's welcome Professor Turing to give us the speech.
Sorry for me. Thank you for kind introduction. The pronunciation of my name is excellent, really. Thank you so much. First of all, I would like to thank all our Chinese colleagues for invitation and for organization of this beautiful webinar meeting, because it is really important. We all understand that COVID infection is very dangerous now in the whole world, but at the same time, we understand that there is a very important regional and healthcare which can influence the organizing of and treatment of such patients in every country. And that's why the experience of Chinese colleagues are very important for us, because they start a little bit earlier than Russia. And now we can use your great experience and especially experience in radiology, in CT imaging, and chest X-ray, and ultrasound for our domestic experience is very important. The second, I'm very proud that this webinar is led by two great leaders of professional societies. From China is Professor Jin, and from Russia is Professor Sinitsyn, well-known physicians throughout the world. And it is a great event, to my mind, for the radiology. And I want to wish success this webinar, and for all of us, I suppose it will be very interesting today. Thank you so much.
Thank you very much, Professor Turing. I forgot to introduce his position in the society. He is the chief expert for radiology of the Ministry of Health of Russia Radiology. Thank you. And so I think now it's time for us to move on to the presentations, and as the schedule was done. And so the first presenter today is Professor Hou Yang. She is the Vice Radiology Department Chair of Shengjing Hospital from north side of China, associated to Chinese Medical College. She is also the professor of the medical imaging and nuclear medicine, the Chinese Medical College, member of Heart and Chest Sub-Society of Chinese Society of Radiology. And she also has a lot of titles. And now let's welcome Professor Hou to present the progress and the prospect on imaging diagnosis of COVID-19. Please, Professor Hou. Hou姐姐，您没开声音。
Microphone is off.
It's okay?
Yeah.
It's my pleasure. Yeah, okay. Yeah, it's my pleasure to give something about progress and prospection on imaging diagnosis of COVID-19. And good afternoon, everybody. And I come from China Medical University. I'm Yang Hou. And first, this is the background. And WHO announced COVID-19 as the name of this new disease on 11 February. COVID-19 is a formidable challenge to global public health security, affected more than 200 countries and regions with over 4.4 million confirmed cases.
好，姐姐。
Okay.
Excuse me, you can share your screen. 你没有共享屏幕 so we cannot see PowerPoint.
Yeah.
Sorry to interrupt. We cannot see your presentation.
That's okay?
Yeah, I think it's coming, but not yet.
Sorry.
No, it's okay.
Okay.
Just a bit.
Oh, yeah.
Firstly, I will introduce something to coronary virus. And the coronavirus genus belong to coronary virus family. The first coronavirus was isolated in 1937. It was an infectious bronchitis virus. Human coronavirus was first discovered in 1935 for nasal versions. And coronavirus caused a large variety of disease in animals such as pig, cows, chickens, dogs, and cats. 5 types of human coronavirus, including the 2019 new code, have been characterized. Prior to the SARS outbreak, coronary virus were only thought to cause mild disease like a common cold or enteritis in humans. And 2019 new COVID is SARS-like bad covers, and it has aspirin attached to host ACE2 receptor, and ACE2 receptor is surprised and is prized widely on alveolar type 2 cells. Using spike protein, the virus can latch onto ACE2 and sneak inside. And most of the patients have mild and moderate prognosis and have a good prognosis. The symptoms of children are relatively mild, and a few patients are in critical condition. Death cases are more frequently seen in the elderly and those with chronic underlying disease. Example, diabetes, hypertension, and COPD or cardiovascular disease. Let me see the COVID-19 phenomena CT imaging findings. And GGO is a common image findings only be seen in the early stage or already mild or moderate patients. And it's usually located in the peripheral lung field, single or multiple. And with the disease progression, a GGO mixed with consolidation is very popular. We can see them in the subpleural area, bilateral or multiple cause. And with the progressive station, GGO becomes consolidations and located in the subpleural area. And GGO with quasi-paving panther or air crime is very popular in the CT findings, and increased opacity density and with enlarged subsegment vasculars and air programs. like the crazy-piving sign in the February. And we can see interlobular septal and interlobular interstitial thickness like a spider web. We named this spider web sign. And this is pitch shadows along the bronchivascular bundle and irregular in shape with blurred borders and like the cloud-like shadow. And this is febrile straps. We can see most of these layers in the progression, especially in dissipation stage, and located in the subpleural area with other signs such as consolidation or GGO. Nodulars is less common image findings. This is a 23-year-old female with confirmed COVID-19. We can see the blurred margined nodulars, and with the disease progressions, it disappeared. And this is two signs of less common image findings. This is a subsegmental vessel enlargement, and this is a pleural effusion. And this is the CT findings were associated with disease progressions. In the early stage, we can see most of the cases showed normal chest CT and with the disease progression and consolidation and biliary disease and febrile distribution is very prominent. And in the later stage, linear opacity and febrile strips is more popular. So in China, in Chinese experience, CSR divided the COVID CT findings to 3 stages. The first stage is early stage, and corresponding pathology is interstitial damage. And GGO is more popular in this stage. GGO with a cloud-like change not obscure the compounding pulmonary vascular structures in lung, and most GGO have blurred borders. And Birch was thinking about gram sign and visual enhancement, blurred border, mild intrabular septal thickening, single or multiple located, and most located in the subpleural area, and some is distributed along the broad vascular border. Note, corresponding pathological changes are exudations in the alveolar cavity with partial filling of the air cavity, mainly from serous and fibrinous exudations, alveolar septal-vascular congestion, and edema. And the procession stage is diversity. GGO from the early stage expand and the density increases gradually. And consolidation with the broken gram sign is popular, and with a blurred border. And the layer range can be acinar, left light, long segment, or long lobar. Mostly in the caudal regions of the lung and dorsal subpleural areas. And the new layers emerge and resemble early stage layers. And in this progression stage, CT findings look like viral phenomena, and layers in different stages non-specific diverse appearance. And this is something about critical stage towards ARDS. Multiple consolidations in both lungs, heterogeneous observations with air program and bronchiectasis. Non-solidations area show patchy ground glass opacity and the whole lung, like the white lung and the bilateral pleura and interlobular septal thickening are common. And the pleural effusion, usually little pleural effusion, free or partial encapsulated. And this is outcome. Outcome is divided to three departments, and this is recovered. The larynx becomes smaller in size, lower density, and absorption. And the scarring forms fibrous strips in short period of time. And the third is deteriorate. Some elderly patients or patients with underlying disease may progress to ARDS, and the CT shows as white lung. And this is a case for the early progression and recovery. This is 46-year-old male. We can see the CRP and the ESR is enhancement. And NAT tested is positive on February 2nd. Close contact history is not certain. And earlier we can see some patches GGO with consolidations in the two sides of the lung. And 6 days later, we can see the larynx is progression gradually. And 5 days later follow-up, we can see the larynx were absorbed and only some patient shadow and the strap and fibrous strands in the two side of the lobe. And another one is a critical case. And this is a 52-year-old male and a fever and a cough for 2 days. A patient's first chest CT taken on January 3rd showed no abnormality, and he paid another visit to hospital on February 7th. Due to shortness of breath, his SpO2 was 97%, and the NAT test is positive. As the patient died on 5th of March, when he was on ventilator, and the cause contest is formative. And the IgG and the CRP and the ESR is abnormality. This is a early CT images, and is almost a normal chest CT. And 88 days later follow-up, we can see the numerous GGO and the patches in two sides of the lung. And 60 days later, we can see the GGO with consolidations and pairing, crazy piping signs, and streams and air, broken air signs. And in the end, this patient is died. And Dr. Liu and his colleagues researched some pregnancy and perinatal outcomes of women with coronavirus disease. And his research included 15 patients and with mild symptoms, only fever or cough. And MG city findings is a focal GGO and a small patches of the grassy pelvic sign and consolidations. We can see this is a progressive stage of a 30-year-old pregnant woman with mild COVID-19. And in the end, this is an absorption. Pregnancy and delivery didn't aggravate the severity of COVID-19. And all cases achieved a good recovery from COVID-19 pneumonia, and 4 of whom didn't receive antiviral drugs. And this is a paper for clinical and CT features in pediatric patients. We can see the different point for adults, and most of them were mild cases and procalcitonin evaluation. And the typical size is ambulatory or ambulatory subpleural GGO and consolidations with surrounding hollow sign, and most of them is with a good prognosis. But recently, in US and Europe, doctors have been warned to look out for a rare inflammatory conditions in children. And these cases have causes similar to a rare blood vessel disorder known as Kawasaki disease. Kawasaki disease is more popular in the East Asia children, but is very rare in the Western children. Symptoms of Kawasaki disease include a high body temperature that lasted for 5 days or more. They also include the skin conditions and swollen part of the snakes. And some cases have symptoms similar to toxic shocking like syndrome. A urinary stomach pain, along with other stomach issues, should be noted. These issues could lead within hours to shock, low blood pressure, and heart problems. This is a key factor behind the differential diagnosis. COVID-19 has the same characteristics like other viral phenomena. It's critical to refer to clinical and lab information, along with epidemiological evidence. Remain vigilant to tailor change of images, refer to pathophysiological mechanism. Be familiar with different or possible image characters of COVID-19 at one service times. Focus on those patients who have GGO with fever, normal WBC count, and low lymphocyte, and resistant to anti-inflammatory therapy. And because of COVID-19 is not have the special CT findings, so many other disease such as non-viral infection, viral infection, and non-infectious disease maybe have the same CT findings. So we must differentiate and be careful. And what is the value and the limitations of the CT in epidemic situations? I will introduce some Chinese experiences and how to choose the right method. In my opinion, we should take we should start think several lists, such as target organ and sensibility, feasibility, and long-term effects. In Chinese experience, for early detections, HRCT is recommended. We recommended the MDCT and normal upper sensing slice and the gantry rotation speed no below 0.4 s, and the thickness is 1 millimeters. And the follow-up, we can use the DR, CT, low-dose CT, and the ultrasound to evaluate the severity, therapeutic effect, and prognosis. The HRCT is preferred. It has very clearly CT findings than the conventional slice CT, and the long ultrasound is as well known. Long ultrasound has many good items, such as portability and bedside evaluations and safety, and the possibility of repeat in the examination during follow-up. In Italy, researchers do something about LUS in the compared the LUS and the CT in detecting lung abnormalities, and they found excellent correlations between LUS and CT. Maybe LUS can be used as a secondary screening modalities or alternative to CT in pregnant and pediatric patients. And this is the significance of CT in COVID-19 diagnosis in Chinese experience. In early we can use the CT in early detection, enable authority to control spread of the disease by quarantine and early treatment. A follow treatment evaluate therapeutic effect and prognosis, and improve diagnosis capabilities. Deduct pathophysiological changes from imaging presentation, may reveal mechanisms. And this is a case of early detections. We can say this is a chest CT images of a 34-year-old man with a fever for 4 days. And this is the CT images on the first of February, and we can see nodulus with a hollow sign in the left side of the lung, and in this time PCR is negative, and with disease progression and follow-up CT in the February 8th, we can see in this time PCR is positive, and the CT findings is very common. And another value is predicting disease progressions. And this is paper is to the purpose is to determine the predictive value of CT and the clinical characteristics of short-term disease progression in patients with COVID-19, and 151 patients with moderate COVID-19 on admission and observed for at least 14 days. And the conclusion is the CT severity score was associated with inflammatory levels, and higher NLR and CT severity score on admission were independent risk factors for short-term progression, and early admission and surveillance by CT should be recommended to improve clinical outcomes.
Important is specificity. We can see this is very large cases research by Dr. I, and the specificity is 25, is very low, and this is a case of fever and cough for 3 days. We can see the GGO, and GGO with consolidations is 2 sides of the lungs. And this is another case. We can see a GGO consolidations, strength, fibrous strengths, and aggressive piving signs. But this is not the COVID-19. This is influenza A. And this is a COVID-19. So image count declares specific types of virus. Be sure to refer to epidemiological evidence, and clinical information requires NAT for suspected cases as soon as possible. And the next limitations is heterogeneity diagnosis. This paper purpose is to assess the performance of US and Chinese radiologists in differentiation COVID-19 from various phenomena on CT, and the accuracy is from 43 to 97. Is a very heterogeneous diagnosis. So, screening COVID-19 using CT is right now, because a single normal CT doesn't preclude the possibility of COVID-19, and the CT can't operate pathogen test since the CT presentation is not specific. When CT doesn't consist with clinical syndromes and pathogen test, be careful not to exaggerate the value of CT. And as to the polystration, we should use the term viral pneumonia instead of COVID-19 pneumonia. And in summary, diagnosis of COVID-19 is still to be confirmed by clinical and laboratory examinations. Chest CT is considered essential technique for evaluation of abnormalities of COVID-19 in early stage, and should serve as an essential technique in evaluation potential complications, disease severities, and progress. And the screening tool is not recommended, and the follow-up are required, and more evidence is needed from studies reporting patients with COVID-19 in other countries. I think we should pay more attention to lung infectious disease. Let radiology play a significant role in MDT, and integrate information from epidemiology and microbiology and infectious disease. And we should be using cutting-edge technologies such as AI, radiomics to improve. This is roles of AI diagnostic systems in the containment of COVID-19. And several AI systems have been used in China, and they can detection of nodular layers at early stage of COVID-19 and early warning of suspected phenomenon, and quickly display and outlines layers and automatic analysis of layering proportions in different lobes and different C value intervals, and automatic registration of prior and primary CT scans and indicated layer changes quantitatively. And I think this is a global battle for a shared future, as it's still possible to control the virus with efforts. And the trajectory is in our hands and as everybody's business. And we should all contribute to stop this pandemic. And this is the end. Thanks for your attention. Thanks a lot.
Thank you very much, Professor Hong, for your wonderful presentation. I think it's really informative with a lot of knowledges, not only with the imaging features, but also for the workflow and the recommendations of when the imaging, the CT, the imaging should be used. I think this would be very helpful. And I think this topic is also open for discussion later after the four presenters giving their presentation. And any audience that you have questions, you can actually type it in the chat room, and so we can see the question now, and I think the presenters can prepare for the answers from now on. And so now let's move on to the next speaker. We are very honored to have Professor Valentin here. He is the president of Russia Society of Radiology, the head of radiology at Faculty of Fundamental Medicine and Radiology Department of University Hospital Lomonosov, Moscow State University. He is also the gold medalist of European Society of Radiology. He is the president of ESR 2014 and also the past president of ESCR from 2011 to 2014. And he is also the honorary fellow of ACR and a lot of social society positions. And so today his topic is the thromboembolic complications in COVID-19 patients. This is really an exchange to all the radiologists today. Please, Professor Valentin.
Yeah, Juan Dan, thank you very much for your kind introduction. Just a moment. Just a moment. After excellent review of general situation and general radiological features of COVID-19 disease, my short talk would be about thromboembolic complications in COVID-19 patients. I'm not going to go into statistics, just would like to show you nevertheless some figures from Russia. Unfortunately now, as you know, now by number of cases, now our country is country number 2 after United States. So we are much above China, having population more than 10 times less than China. Nevertheless, we have very high incidence, as you see, biggest in Europe. And still, as you see, if you look at this curve, growth is slowing down, but we hope it's approaching to the plateau, but so far it doesn't look like a plateau, but we are hoping for better. One good thing is that, as you know, mortality in our country is very, very low. So far we have less than 3,000 deceased patients. But Another bad story, but bad story is that we have relatively high incidence of infection in medical doctors and some death cases, even in radiologists. But speaking about COVID, we know from the previous talk we've seen the pathogenesis of the disease, and we know that it's a multi-organ, multi-system disease, and many patients die not only from pneumonia and respiratory failure. Many people die in combination respiratory failure together with acute heart failure. And if you look into this chart about cardiovascular involvement of COVID-19 from European Society of Cardiology, you see that AC receptors located, as you know, in the blood vessels. They are very abundant in the lungs. That's why lungs is target number one, but also they're plentiful in, as I said, in capillaries, in the heart, in the bowel, in the peripheral vessels. So that's why there are so many clinical manifestations of this disease. And we know that there are already several well-known first papers. More papers are coming about autopsies, pathologies, and pathologists. They were surprised that these cases they didn't look like a common pneumonia. They found diffuse alveolar damage, and 40 of hemorrhage, and multiple small thrombi inside capillaries and small vessels. You can see this arrows indicates to the small thrombi and dark sides of hemorrhage. And the same in the next paper about autopsy findings from Germany. As you see, they even tried to perform virtopsy, post-mortem CT, and they found a high incidence of deep venous thrombosis, and acute pulmonary thromboembolism was the cause of death in 4 patients, and they found the same signs of diffuse alveolar damage and microthrombosis of pulmonary vessels, not embolic lesions, but thrombotic lesions, and of course, very high concentration of the viral RNA and large substantial amount of viremia and viral bodies in the tissues and organs. And I like very much a term in one from the recent papers about speaking about lungs. It's a pulmonary intravascular coagulopathy in patients with COVID-19. As I mentioned already, because of attraction of the virus to AC2 receptors, that's why we see such a prominent pathology in the lungs, alveolar damage together with multiple thrombosis. And you can see on the right slide, we can see multiple manifestations in all internal organs, including skin. Yes, we heard about Kawasaki disease, about skin lesions in pediatric patients. And in our hospital, we see some adult patients with skin rashes. It's also quite a common manifestation. And again, coming back to the lungs, you see multiple infiltration with macrophages, with neutrophils, with release of pro-inflammatory mediators, and formation of microclots into the microcirculation, signs of vascular rupture and hemorrhage. That's why all of us know that today a lot of attention is paid to anticoagulation therapy. As far as I know, now it's a standard, it's a basis for therapy in COVID patients. For example, in our hospital, every patient without contraindication gets a low molecular heparins as a part of the treatment. And European Cardiological Society, they issued several documents stressing importance of the problem involvement of the heart and vessels in COVID infection, and societies on coagulation and thrombosis. They also issued quite earlier documents stressing the significance of this problem and the deep disturbances of the coagulation and anti and procoagulation systems in this patients because many of them, they have signs of disseminated thrombosis, bleeding, and consumption coagulopathy. That's why role of anticoagulant therapy is one of the most important. And we know from already publications that patients with high levels of the dimer, sorry, I hope it's not COVID, they had high mortality and more severe forms of the disease. And again, thanks to our Chinese colleagues, the first publications came from China about high incidence. First, there were case reports about cases of the pulmonary thromboembolism in patients with COVID pneumonias, like this one and the next one. And after that came papers from Italy saying that could it be a coincidence, or is it, well, some links related to pathology? And now it's not everybody knows that it's not a occasional link. It's not random association. It's related manifestations of COVID infection. As I said, pulmonary vasculopathy. I would like to show you some, because I'm working in COVID hospital. So you can see a case, a typical case of COVID pneumonia with multiple ground glasses and consolidation in patients. But after several days, we witnessed a quick rise of his dead dimer values, and we performed CT angiography, and you see multiple thrombi in the right pulmonary segmental branches of the right pulmonary artery, and the same. And you can see after that, after start of the thrombotic therapy, we can see some regression. A week later, a consolidation and fibrotic changes on sites of previous ground glass areas. Next case, again, a lady overweight with a mild form of COVID pneumonia, positive PCR test, but nevertheless, again, she experienced a severe dyspnea with increase of dimer values. And again, in her case, we see multiple left and right-sided thromboemboli in the pulmonary vessels. And in that case, we see a substantial overload. We see dilated right heart chambers, right ventricle, and the right atrium, comparing with the left side. So it shows high pulmonary hypertension and overload of the right heart chambers. So already there are quite big studies. For example, this one is a recent one from France, from Gruyère, with co-authors who reported 100 pulmonary TTA in 280 patients with COVID-19, and they found 23% incidence of the acute pulmonary thromboembolism. And of course, clinical manifestations of the disease were more severe in these patients. And it was again related to COVID, because actually there was no difference between comorbidity, saying about cardiovascular disease, oncology disease, between patients with pulmonary thromboembolism and without it. And just a case from the paper. Again, we see how you can guess from the images. You see almost white lung, but high levels of dimer, and you see multiple thrombi. In the next case, less severe case, but nevertheless multiple thromboemboli. And in another recent paper, author found that levels of dimer were much higher in patients with acute pulmonary thromboembolism detected with CT angiography. But in general, you see people, patients without pulmonary thromboembolism. Also, as all of us, we know that COVID patients, many of them, they have increased levels of their dimer because of systemic coagulopathy and probably small microthrombi, which couldn't be visible on CT images. I mean, on CT angiography, and so probably you should do perfusion CT to see such cases. And you see that level of dimer more than 2,660 had 100% sensitivity and 67% specificity for prediction of the acute thromboembolism. And in study of this group, also they found acute pulmonary thromboembolism in 1/3 of COVID patients. Yes, many of these patients, they're intensive care unit, but we know that usually it's between 3, 5, 10% of ICU patients, they have pulmonary thromboembolism, but because this incidence is very high. And again, from another paper, you see that multivariate model to predict pulmonary thromboembolism, the most strongest predictor, of course, it was that the dimer increased by more than 6 milligram per milliliter, or a history of the previous thromboembolism, which is of course quite natural, and obesity, large body mass. And this is, our good friend Matthias Oudkerk and his colleagues from the Netherlands. Recently, they published a view on the same topic about importance of the thrombotic complications, and they published a case. It's so far not a group. It's a case of perfusion CT in patient with COVID pneumonia. Patient hadn't signs of diffuse pulmonary thromboembolism on CT images. No macrothrombi in the pulmonary arteries, but perfusion CT demonstrated severe perfusion defects in the lungs, which against says us about importance of the indicates microthrombosis in the lungs. And well, I'm coming to the end of my talk, but in literature you can find so far it's case reports, but more and more cases about myocarditis, fulminant myocarditis in patients with COVID pneumonia, or cases of the necrotizing encephalopathy with the signs of hemorrhage. You see on these SVI images, you see these dark parts, or bigger series with 27 patients. Again, 37% had signs of diffuse cerebral anomalies, signs of encephalitis, inflammation of arachnoidites, microbleedings. Again, you can see here in the bottom row, you can see signs of microbleedings and contrast enhancement of the leptomeningeal enhancement. So again, showing us the signs of diffuse vasculitis. And recently, for example, we had a patient with acute abdominal pain, and we have seen thickened bowel loops, looking like we thought that it could be some colitis or enteritis, maybe because of antibacterial therapy. But just recently appeared a paper about very high incidence of the enteritis, signs of ischemia and necrosis, even bowel gas in the wall, on the bowel walls, seen in such patients. 4 patients were operated, and in 3 of them, surgeons found signs of bowel wall necrosis caused by coronavirus infection. And all of us, we remember that for coronavirus, for IC, density of IC receptors is also very high in the bowel. So we shouldn't miss such cases with involved when disease involves not only lungs but also bowel. And coming to the end, again, we see this, it's COVID-19. It's not a classical virus pneumonia. It's associated with the high incidence of thrombosis, hemorrhage, and vasculitis. Major targets are lungs, heart, bowels, brain, and skin. And when we see high levels of D-dimer, or when we see a rapid increase of D-dimer levels together with the clinical picture, clinical signs, we should think about adding performing CT angiography, because usually we do just a plain chest CT and we cannot be sure about signs of CT. Of course, perfusion CT could be better, but in the setting of the pandemic and trying to protect our staff, doctors and radiologists and radiographers, we cannot do perfusion CT or even CT on the large scale. So we should think maybe better about indications. And of course, further studies are needed. And thanks to our friendship, to our communication, international communications in general, and with our Chinese friends in particular, I'm sure that we will be victorious over COVID-19 pandemic all over the world. Thank you very much for your attention.
Thank you, Wellington. Thank you very much for your excellent presentation. I think, yes, I think PE is not only the only complication for COVID-19 besides the pulmonary lesions, but actually, as your later the content of your later presentations, actually, this is already being recognized to be a multi-organ disease, and so it is not only the pneumonia, but also the heart, the kidney, the brain, and maybe also of course the bowel, and so this could be a systemic disease already. And so, and also what we see now in China is that this disease has become a continuous existing disease with human beings. And also we know that recently some news from the WHO said that maybe COVID-19 can be a long-lasting disease with human beings for a longer period of time. And so this is no more an explosive feature, but a continuing to exist feature. And so I think this multi-organ problem could be a hot topic in the future. Thank you very much, Wellington. And so now let's move on to the next speaker, Professor Huai Chen. Professor Chen Huai is the Vice Department Chair of the first affiliated hospital to Guangzhou Medical University, and he is also a member of Imaging Diagnostic Committee of the chest in Guangdong Province. Actually, Professor Chen just returned from Iraq to China because he was a member of the International Supporting Program of China. He is the member of this Red Cross supporting expert group to Iraq for helping them fighting through the COVID-19 pandemic. And so we really appreciate for your effort for presenting today. And so now let's move on. And I believe that Professor Chen will bring us a lot of experience from his fighting. Thank you, Professor Chen. Please welcome.
Good afternoon, everybody. Thank you, Professor Shedd, for introductions. It is my honor to have the chance to discuss with the radiology of Russia. And as you know, now the COVID-19 is global pandemic. So as a radiologist, what can we do in these battles? But today I will talk about the imaging characteristic of COVID-19. And in the next 20 minutes, I will talk 4 main points, but just briefly touch about the epidemic situation and the clinical feature and differential diagnosis. And I will more focus on the imaging findings. So first, let me show you the situation in China. For now, we know a total of 84,500 cases have been confirmed in China. But now we will just existing diagnosis is 115 cases. So actually I can say that for now, China, the epidemic situation is under the controls. But today we were more worried about the situation of the global epidemic situations. As you know, on March 11th, WHO declared the novel coronavirus is global pandemic. For today's, and the global confirmed case is near 5 million. And also, I see the situation in Russia is not so good. It's nearly 300,000. So first, I will show the etiological characteristics. As we all know, the coronavirus is belong to the beta coronavirus, there is a significant difference between the coronavirus associated of SARS-CoV and MERS-CoV, but it is also sensitive to ultraviolet and heat. And for the epidemiological factors, we all know the infected patient with COVID-19 is the source, but now they have another group of patients. There is a symptomatic infected person also can be the source of the infections. In my experience, I think that this part group of patients is more dangerous because we don't know who is the symptomatic infection patient. And the transmissions, I think droplet and contact transmission is the two main transmissions. So for the droplets, we need to use the mask. Use mask, we can protect ourselves and also we can protect another ones. So for the contact transmissions, I think wash the hand is another ways. But maybe you will heard something that it can spread by aerosols, but it just the aerosol is in a relatively close environment and it stays in a long times. But all the people are susceptible, from the infants to the seniors. All the people is susceptible. So for the clinical manifestations, I think the incubation period is 1 to 14 days, but most case is the onset is 3 to 7 days. They have 3 main manifestations, include fever, fatigue, and the cough. But many cases have the dry coughs. But a few patients, they have accompanied by nausea, obstruction, and nausea discharge all throughout the road. But I think maybe the patient is just feels there's like the flu. But most of the severe patients, they will develop a shortness and dyspnea. Some cases, they will develop to the ARDS. But actually, I need to say this. Most of the patients have a good prognosis. Maybe they were more than 80%. The patient is good prognosis, but a few are in critical conditions. And for the laboratory examinations, there were 2 kinds of. One is conventional examination. As we know, the white blood cells is normal or decreased, and the lymphocyte is decreased. In some cases, the C-reactive proteins often elevated, and in the severe case, the D dimer increased and the lymphocyte is decreased. And for another kind of lab examination is etiological and serological examinations. As we all know, many the country will use the RT-PCR to confirm the case. But in my experience, some the case we often get the false negatives. Maybe some case they have 2 to 5 times we get the negative result. So the detection of lower respiratory tract is more accurate, and the specimen should be submitted as soon as possible. And for the serological examination, now many countries use the IgN and IgG antibodies to confirm the case. But as we know, the IgN is positive on outer onset 3 to 5 days, and the IgG is in the recovery stage, and it needs to 4 times higher in the accurate circulation. And how to definition the case? In China, we have 2 steps. First one is we will find who is the suspected case, and this is have the epidemiological history and clinical manifestations. And for the clinical manifestation, they have 3 points. Number 1 is you have the fever and fatigues or coughs. And number 2 is for imaging characteristics. If X-ray or CT, we show the pneumonias. And the third one is the number of the white blood cell is normal or decreased, or lymphocytes is decreased. If there is any epidemiological history, it conforms to any 2 clinical manifestations. But if there is no clear epidemiological history, it conforms to 3 clinical manifestations. But for the confirmed case, and the suspected case with one of the following etiological evidence. And the first one, the PCR is positive. Another one is the viral genus is highly homological to the novel coronavirus. And the last one, we use the IgM and IgG antibody is specific to novel coronavirus was positive. This is for the confirmed case. But in here, we use the CTs for screening progresses. But actually, I should say this. This is just for earlier stage in China. And also in the Iraq, we use this ways to screen the patients. Because the patient is fevers, we use the CT for the first times. And if the positive, you need to use the PCR. If negative, we will follow out. But now in China, actually I need to say we will both the same ways. The CT and the nucleic acid detection is the same. We do both of this. And let's focus on the imaging findings. For the X-rays, I have to say this. I don't like to recommend use the CT, use the X-ray for screening, because as you know, in the earlier stages, maybe many the case we will get the negative first result from the X-ray. So it's more easy to miss the cases. But with the progress, the lesions show the thickening of the bilateral line marking and consolidation shadows. And the lesion where distribution was mainly in the lower lobe. And some severe case, they will show us the white lumps. Let me show you some case. This is 25-year-old female, and the COVID-19 PCR is positive. We can see the patchy shadows of the right middle lumps. And after treatments, and the lesion was basically absorbed. This is another case, 57-year-old males, and it's just come from the Hubei province. And in the first days on sepsis, there were no definite abnormals we can see in the X-ray. But after 3 days, and the multiple high densities in bilateral lumps, we can see it. But in here, for the serious and the critical novel coronal pneumonias, and as you know, the lesion changed very quickly. And just for this case, in the February 4th, we just see the several small patchy shadows. But after 1 day, they have many the multiple patches. But after treatment, and the lesion was absorbed significant. And this is another case. And for fever for half days, and is abnormal on that days. But after 1 week, we can see the consolidation in both of the lumps. But after treatment, and the lesion was gradually absorbed. Another case is the critical U patients. We can see that this is very high densities. This is wide lumps. So in my experience, use X-ray for screen. I don't like to recommend, but if for the monitors the patients the progress, it's very useful because you know for the serious or the critical patients, they cannot come to the department of radiologists. So for this part of the patients, we can use the portable X-ray machines for monitors. And as we know, the CT is used very popular for the COVID-19. And the first ones, we can see the multiple patch shadow or segmental ground glass opacities. Another ones, the lesion was often located in the subpleuros, and seldom people, they will pleural effusion and enlarge the nodules. So this is the CT imaging findings. Include is GGO and consolidation and reticular shadow and traction bronchitis and subpleural leanness, crazy paving side and reverse hollow side, and pleural effusion and the pneumothorax. First ones, as we know, the ground glass opacity is the most common side, but which it can localize or diffuse. But in my experience, many cases is diffuse, and they will mainly distribute under the pleurals. And let me show you this case is 58 years old. We can see is the lower right lower lows and right lower low and right middle low and the left upper low and left lower lows. They have many lesions. And this is another case. The 65 years old male feverish for 1 week. I think this is more typical. We can see the diffuse, the ground glass opacity is located under the pleurals. But some critical U patients, we also can see the ground glass opacities, but it often combined with the consolidation in another side. But in the ground glass opacities, we can see the small vessel, but the small vessel is thickening than the normals. Consolidation is another common side. But in the consolidations, we can see the air bronchial gland side. This is a 25-year-old female. Is fever for 1 day. The CT shows the consolidation of the right middle lungs. It also can be seen the ground glass opacity around it. And we can see that in the consolidation, the air bronchial gland side. But in the critical case, we can see that many the multi-consolidations showed in both of the lungs. Another side is the reticular shadows. Just we can see that many the ground glass of cities located in the subpleural, and we can see the very typical the reticular side, and in the lobular septum is thickening. This is show you the traction, the bronchiectasis. In the consolidation, we can see the bronchia, but the bronchia is enlarged than normals. But this size is more often happen in the critical U patients. Just for this case, we can see ground glass opacity and consolidation. And in the consolidation, we can see the transient bronchiectasis. And in the later stage, we will find the subpleural linear opposites. In this case, you can see the less subpleural involved, but we can see the subpleural linear was seen. This case is more happen in the later stage. And for the creating paving side, an extensive ground glass opacity and grid shadows. But some cases, they will show us the river hollow side, just like we can observe from the coronal position or the sagittal positions. But sometimes they will change from the consolidation to ground glass opacities. And the pleural effusion is another side. But in the early stage, maybe many the paper is published, they said the COVID-19 imagines seldom pleural effusion. But in my experience, because in our hospital, we will many the critical and severe patients, I found many patients, they have the pleural effusions. And this is 72 years male is critical EU patients. We found in the left, we have the pleural effusions. So in my experience, if we found the pleural effusion, we need to worry about the heart functions. Some cases, maybe they have the pneumothorax, but this case is just alter the endotraction in incubations. Now we can see that some cases they have the pneumothorax. This is another case. We can see the left, the pneumothorax. And according to the scope and evolution of the lesion, the CT finding of the novel coronal pneumonia can be divided into 4 stages. And the first one is early stage, and the second one is progressive stage, and the third one is the serious or critical stage, and the last is convalescent stage. But for the earlier stage, I think the ground glass opacity is the most common findings, and the lesion can be located and diffused. But I just said the diffuse case is more often considered, and the lesion mainly distributed in under the pleurals. This case I have so used. We can see that many lobules, they have the ground glass opacities. This is another case from Xi'an Jiaotong Universities. And in the first scans, we can see the right upper lobes, it's just ground glass opacities. But after 3 days, we found many the lesion is happen in the many lobes. But for the progressive stage, the lesion progressed and increased, and the scope expanded, and multiple lobes were involved, and consolidation shadow is increased. And many the case is GGO coexisted with consolidation and the strip shadows. Some case they have the pleural effusion. This case is 57 years female. We can see the consolidation in both of the lower lobes, and also can see the pleural effusions. This is another case. We can see in the right upper lobes, it just can see the ground glass opacities, but after 1 week, we can see this disease is progressive, and it from the ground glass opacity to consolidations. And for the critical or the severe patients, and diffuse the lesion of both lungs, but without clear limits. An extensive consolidation and air bronchial gland sign were common to observe, accompanied by the lobus or segment atelectasis. But some cases we showed wide lumps. And just as stated, most patients, they were pleural effusions. Let me show you this case. You can see the multi-consolidation in both of the lungs, but we also can see the pneumothorax and the pleural effusion. In this case, also can see the pericardial effusions. If the case, I think, is very difficult for the clinical doctor to treatment this. And it's the same case. We use the cortical X-ray to monitor, but it also show the wide lumps. But sometimes you change the very slowly. This is another case. It's changed very quickly, and just for 2 days is all the left lump is consolidations. Is look like the wide lumps, and also have the pneumothorax. And for the convalescent stage, and the lesion area and density is decreased. Some case from the consolidation shadow to into the ground glass opacity, and the lesion could disappear completely or remain a little fibrosis shadows. This case is 25-year-old. For the basic scans, you can see consolidation and ground glass opacity, and after 10 days, and the consolidation is gradually absorbed, and the ground glass opacity is absorbed. And after 20 days, I think the lesion is basically absorbed. This is another case from February 13th. This case, we can see the consolidation and fibrosis and ground glass opacity. But after treatment, the consolidation is absorbed, and we just can see the ground glass opacities. This is another case from the consolidation and ground glass opacity and fibrosis. And the last scans, we can see that all the lesion is absorbed. And the last, I think if the CT scan is positive, we need to differentiate many diseases. But in my opinion, I think the coronavirus need to diagnose, differential diagnosis is with the another virus, just like SARS and MERS, and influenza virus, adenovirus, pneumonias, and maybe the CNVs. So all kinds of the pneumonia we need to think about it. So I believe that through the work together, all the people of the world, we will soon be able to communicate face-to-face freely. And I hope the situation is better and better in Russia. Thank you for your time. Thank you very much.
Thank you very much, Professor Chen, for your wonderful presentation and all the experiences that you bring out and share with all the audience. Thank you. And so I think your all the content is very helpful for the daily practice now. And I also learned a lot. So we are now, I think it's time for us to move on to the next speaker, Professor Igor Turin. He is the chair of the Department of Radiology and Nuclear Medicine of Russia Medical Academic for Continued Medical Education. He is also the chief expert for radiology of the Ministry of Health of Russia Radiology, and also he is the member of Russia Society of Radiology, the member of Russia Society of Thoracic Radiology, and so on. And he is also the member of RSNA and ESR and so on. And so now let's move on and welcome Professor Turing for the topic of imaging of COVID-19 pneumonia in general hospital case-based review. Let's welcome.
Thank you so much, dear colleagues. I hope you see.
Yes, I can see.
Yes, okay. Thank you so much. Thank you, colleagues, for inviting me once again. And I'm very pleased to talk a little bit about presentation of COVID-19 pneumonia in a general hospital. Why it is so? I try to be very brief because we are working about 1.5 hours. But why it is important for me and for my colleagues? In our country, there is some differentiation for the treatment of the patients with COVID-19 infection. We have a special departments and special hospitals for patients with COVID infection, and all imaging science for this disease were described in details in the previous lectures. But at the same time, we have a general hospitals without any separation of people in whom suspect or not suspect COVID-19 infection. And to me, much more important, we have several other diseases, especially the diseases in the chest cavity, the cardiac disease, oncological disease, hematological diseases, and many, many others. So we need to understand what to do with these patients, because the risk of COVID-19 infection in this population is relatively high. And that's why we need to understand the imaging patterns of COVID pneumonia in patients in general hospital, especially in patients, in medical staff, in non-medical staff, which is also important. And I will talk a little bit about this problem. I also want to say a few words about the patients with another chest disease, for example, lung cancer or interstitial lung disease or lymphoma or something like this, and the principles and the possibilities of diagnosis of COVID-19 pneumonia in such category of patients. And of course, a few words about differential diagnosis, because it is a very important task for all radiologists inside the general hospital, because we need to differentiate the COVID pneumonia imaging pattern from other patterns which may be quite very close to this disease. So we understand that we need to prepare our radiology department, both in COVID department and COVID hospital and in general hospital, in order to minimize risk of the for medical staff in this for this infection. And Professor Sinisen said that in our country, unfortunately, we have a relatively high mobility of medical staff in the hospitals. And of course, we need infection control and deep cleaning of all imaging rooms. And we need to think about the transferring of general patients from and out radiological department, especially in cases when we suspect COVID-19 infection in this patient. So it is important, but it is very well described in numerous guidelines from the world, in international guidelines, and of course in national guidelines. But what is important? The diagnosis of COVID infection, of COVID pneumonia, of changes in lung parenchyma in patients with suspected COVID infection is very different, to my mind, very different in comparison on general population. Why? Because CT in the hospital is the primary and the main imaging tool for all patients. We all know the guidelines, and we know that CT is not, of course, indicated for the screening of COVID-19 infection in patients without any symptoms, but PCR positive results, and for patients with mild presentation, clinical presentation of viral infection. But in hospital patients, it's very different because inside the hospital, the patients with even first presentation, the beginning presentation of respiratory infection is located just near the radiological department. And that's why chest X-ray is not an option for these patients. We need to find the very early presentation of the disease on the first, second, or third day of the disease, and that's why chest X-ray is not a very good idea for such patients. Of course, we use chest X-ray as a portable device in intensive care unit, and you hear just before me an excellent review of the possibilities of portable chest X-ray as well as ultrasound for evaluation of pleural cavity and subpleural parts of the lung, for diagnosis of pleural effusion and pneumothoraces. And standard chest X-ray, especially in imaging room, is not very popular in our country for patients with suspected COVID inside the hospital. It is a difference, and we need to understand this difference in the planning of our work. What does it mean? It means that we much more often see the very beginning of the disease, and it is the early ground glass opacities may be very small in location, which may occupy one segment or one lobe of the lung, and it may be interpreted as intermediate or probable COVID infection, COVID pneumonia, viral pneumonia in such patient, because it is a very early presentation, but it is very typical with round or subpleural ground glass opacities with visible enlarged vessels and air bronchograms inside the areas of consolidation and ground glass. And of course, we can see the classic presentation of COVID pneumonia, COVID changes in lung parenchyma with, as I have already shown, and many before me shows this, that round areas of ground glass as well as subpleural distribution of the disease with pure ground glass. And this is typical in hospital patients with a fever, with cough, with shortness of breath, and other symptoms of respiratory infection. Of course, we can see at presentation and much more progressive disease and the signs of so-called organizing pneumonia, when the ground glass changes to the small areas of consolidation, and we see there the clear subpleural distribution and ground glass and consolidation, and the typical reverse hollow sign for these patients with the formation of organizing pneumonia in the early stage of the disease, which is, of course, a good prognosis for such patients. And at the same time, in hospital, we can detect the patients with a progressive disease, with a dense, ground glass and consolidation, the air bronchogram, which is very close to critical disease for the severe disease. Of course, sometimes we need to send them to the intensive care units. And finally, of course, it is a features and the pattern of adult respiratory distress syndrome with diffuse ground glass with peripheral opacities and visible air bronchogram and hyperinflation of the base parts of the lung, and of course such patients are located in the intensive care unit. But what about the differential diagnosis? What about the signs of another diseases? So we know that in all patients and in hospital patients, PCR is not a good idea because the sensitivity of this test is not 100%, and sometimes we even see false negatives. We know also that all imaging signs are non-specific. Of course, we realize that during the breakout of COVID infection, the most sign, the pattern, the classical pattern of the disease is very diagnostic. And we, of course, try to find the signs of diffuse alveolar damage, which consists of ground glass and consolidation, and some additional signs like crazy parent signs and reverse hull sign and so on. And of course, distribution, ground glass, consolidation, and distribution, multiply, patchy, bilateral, or often subpleural, and often with lower predominance. But not often, not in all patients. So we need a probability for the radiological conclusion. Of course, in hospital patients, it is extremely important because we have patients with another diseases, and we try to explain for physicians how what is the probability of the disease. So you know, of course, the typical, intermediate, and typical, non-typical presentation of the disease, and probability, and the possible conclusion of radiologists for this disease, because it may be frequently and more specifically for COVID pneumonia or viral pneumonia, for example. It may be non-specific enough for the diagnosis, and it may be totally uncommon with very low probability. What does it mean in a practice? This patient was admitted to the hospital. With a clinical diagnosis of thyroid cancer for surgery, and it is a chest X-ray before surgery, before 5 days of the surgery. After the surgery, he feels chills, sore throat, and fever, and he was sent to the chest X-ray, though it is not obvious and not in our diagnostic, but what we can see, of course, the tube in the place of the operation, and new infiltrates throughout the lung, in the upper lobe and the paramediastinal part of the chest, and corresponding image with CT show the typical presentation of early COVID infection, which is very important for such patients. So it is not typical for general population that we see the normal and abnormal chest radiography and can compare for a few days and send this patient to CT for more thorough investigation. But in hospital patients, most often have a probable CT and radiological pattern of the disease. It means that we detect the disease in the very early stage, or we have a mixture of COVID presentation with a predisposing disease, for example, interstitial lung disease, lung cancer. And these findings together may be common in COVID-19 pneumonia, but may be seen in wide variety of the diseases as well. So we are not so confident for the diagnosis in these circumstances. This is one of the last example of this feature. This patient had a huge lung cancer, huge mass with cavity, and a total obstruction of the right upper lobe. And of course, it is a lung cancer. But what is here? Is it really he have a fear, he have fatigue, he have cough? Is it really COVID infection, COVID pneumonia? We don't know. It is a very close in presentation. Of course, here PCR negative result on the time of presentation. But is it possible to be aspiration, for example, from this cavity, blood aspiration in cases of lung malignancy? Of course, yes. Is it possible for any other viral infection in such patients? Yes, of course. So it is not typical. It is intermediate, of course, presentation of the disease, and this disease needs a confirmation for the other methods. It is important that the majority of patients with the previous disease inside the chest cavity have the similar conditions. And non-typical pattern, which include a large number of different symptoms, such as lobar consolidation, train blood capacities, mass at, we see these cavities, septal lines, which present atypical features of the disease, and the probability of COVID-19 pneumonia in these patients is very low. And you can see these all patients during the last 2 weeks from the general hospital on the one side, and from the oncological hospital to the other side. And we can see the bronchopneumonia, the metastatic disease, the lung opacification, ground glass opacification near the osteophytes from vertebral body, the condition which is not related to the COVID infection, of course, the lung abscess, and heart congestion, and of course interstitial lung disease and non-specific interstitial pneumonia, which can be quite close in the radiological presentation and clinical presentation for the COVID infection. This is one of the examples of aspiration pneumonitis in patients. He is 46 years old patient with esophagus adenocarcinoma and placement of stent into the esophagus because of progressive stenosis. You can easily see the stent and the signs of aspiration pneumonia. Is it possible to say that this is COVID infection? I suppose no. It is very difficult to understand what is it. No confirmation for any COVID pneumonia until now. We have no until now nowadays. So it is of course aspiration pneumonia, but is there any COVID infection? It is a very difficult question for radiologists, and that's why multidisciplinary discussion with the physicians, for surgeons and oncologists is necessary for these particular patients. Of course, like in this particular case, this is a patient, a female with invasive thymoma in the anterior mediastinum, and the result of the surgery, great surgery, the resection of the anterior chest wall with a special construction in this place, but she have a clinical presentation of something mild presentation of infection. What we see on the 4th day after the surgery, we see the signs of pleural effusion, lineal atrocities in the left lung, and consolidation, as well as small areas of ground glass. What has happened without any specific infection? This is the bacterial pneumonia, and these patients receive the conventional, simple antibacterial therapy for hospital-acquired pneumonia. So it may be quite close to coronavirus infection, but it is not coronavirus infection in this particular case. Maybe maybe a little more difficult case for discussion. This is a patient who have COVID-19 infection, and she have a treatment for the COVID infection, and we know that she have a very typical classical presentation of this disease. The treatment was ended, but after the treatment, she once again felt the dyspnea, and the result was a new CT examination inside the pulmonology department in the hospital. What does it mean? The changes which are specific, which are very typical to COVID infection, are disappeared, but we see the numerous lineal reticular changes here in both lungs, the septal lines, of course, and we see numerous central lobular nodules, ill-defined nodules in the both lungs, especially in the right and left upper lobes. But the ground glass is now not evaluated in the both lungs. So what is it? And it is a difficult problem, especially for radiologists and for physicians, because we have strange areas of hyperinflation in these patients, and we can't explain it as a result of the previous COVID pneumonia. So it was evaluated as a drug-induced pulmonary disease, which is a result of the treatment of these patients with monoclonal antibodies, and these changes have a positive follow-up for next days. And finally, the differential diagnosis with other respiratory infection, because it is important that once again we have some typical presentation of pulmonary infection inside the hospital-based patients, for example, like this, with evidence of with a clinical feature of respiratory infection, of course, but we see here the local presentation of the disease in the right lower lobe, and this presentation is in bronchial thickness and obliteration of the bronchial lumen by the fluid, and it is very typical for, very characteristic for local bacterial disease, of course, like a bronchial pneumonia in this particular case of patient with prostatic cancer underwent radiation therapy, and this particular case had a Haemophilus influenza as the etiology of the disease. Another patient, 22 years female with Hodgkin lymphoma, with high-dose chemotherapy, and at the time of beginning of the clinical signs of respiratory infection, and she is in granulocytosis, and he had 4 days history of dry cough, dyspnea, and fever, and it is a very strange condition for classic presentation of COVID-19 pneumonia. And we discuss here a lot of different infection and non-infection diseases. For example, pneumocystis infection is very likely in this case. But the upper lobe predominance and diffuse distribution of ground glass is not typical for COVID infection pneumonia. This particular case, patient have CMV infection with good resolution after the special treatment. And I suppose one of the last example in my presentation, it is a patient, 48 years old man with gastric lymphoma in oncological center and immune stenosis after the treatment of the lymphoma. And now he need to underwent the surgical resection of the stenotic part of the immune, but it is not possible because surgeons send this patient to the chest X-ray, to the CT, and radiologists find numerous multiplying nodules and reticulation in the both lungs, and even reverse hollow sign in the left lung. is it COVID infection? It is very difficult. But what we know, what we see in this patient, of course, is attraction from bronchiectasis and twin bud pattern, and clearly signs of aspiration and thickening of the bronchial walls. And in this particular cases, of course, we try to find any infection. We don't know why, what infection, but I suppose it is not so likely to be a viral infection. And to me, and for many radiologists with me, such presentation may be typical for example, mycobacterial disease or non-tuberculous mycobacterial disease. And it was detected soon after the investigation. It was MAC infection in this particular patient. So the differentiation is not so simple in case of hospitalized patients, in cases of general hospital, because we always need to remember that patient symptoms may be acute and chronic, and consolidation and ground glass have a hard, big, large list of differential diagnoses. And organizing pneumonia, bacterial and viral pneumonia are the first lines in this list of differential diagnoses. So every time when we see some changes in lung parenchyma in patients, we need to decide, is it typical, non-typical, or intermediate, and try to explain this in cooperation with the clinicians. Thank you so much for your attention.
And thank you so much for your presentation, Professor Turing.
Thank you.
I think all your cases are very helpful, and especially for the differential diagnosis, I think it could be informative. And also, I think for the patient who has the pre-existing pulmonary disease, I think the differential diagnosis as well as the diagnosis of NCP could be very difficult. I think maybe in the future we can do some cohort study for such kind of patient if possible. Thank you very much. And so, I think time is very limited, and so we don't have much time for discussion. So if everybody doesn't mind, I think we can have 5 minutes for questions and answers. I think there are two. I think there's one question from the audience at the very beginning, and Professor Ho has already answered. I'm not sure whether everybody can see it or not. I actually it is about the differential of COVID-19, and Professor Ho actually listed he actually differential diagnosis of other virus pneumonias, and also Professor Turing actually answered part of the question as well during his presentation. And I think there's I think there's more question from the audience, but if possible, I think all presenters are now online, and I'd like to have one question from myself, because now in China we have a lot of, not a lot of, but one, now and then we have this asymptomatic COVID-19 patient. So if one citizen, not the patient, but person who has contact with the patient with COVID-19, but the person, he himself does not have symptoms. And so do you have any recommendations whether this person should receive imaging examination, including either CT or X-ray, or what else should the person receive? Professor Wellington, can you give us some recommendations?
Yes. Probably also Professor Turing, you comment, it's actually a big issue in our country, because in the first talk, we've seen presentations about indications for no indications for CT use it as a screening, but from other side, really you can run a fever clinic like you do such center in China. We have similar centers in Russia, so it's very controversial issue. My point of view is still we should be looking at clinical presentation and laboratory tests, because actually in asymptomatic patient, there is no treatment. So probably the patient should be isolated for some period of time, waiting for repeated negative or positive tests. Because from my point of view, findings of the mild ground glass in his lungs, you bring nothing to his diagnosis. There is no indication for hospitalization, for bringing him to hospital or to any kind of medical therapy. So I believe it's quite a reasonable approach, which is, and this is recommended by many societies. By the way, like in your country, me and Igor, we are members in the board of our society. So we also wrote local guidelines about using of the diagnostic imaging in COVID pneumonia, which is, and they're quite similar to guidelines written by other national, international society. So we recommend very limited use of CT only as a part of these fever clinics, or of course in the hospitals. In hospitals, like in your country, so every patient who is admitted to the hospital with suspicion to COVID, he gets CT, because as you know, in some European guidelines, like I can cite British guidelines, you know, they recommend to start with chest X-ray, saying that you know these guidelines. So, but in reality, we've spoken with our colleagues from Germany, from France. Everybody does CT for inpatients, for hospital patients. Okay. So this is my point of view. Igor, do you want to add something?
Yes, I can add a few words about it. I suppose that is a problem for such patients with the contact of COVID infection. I suppose the problem is in local resources. And it's true that we try to point it out in our recommendation, domestic recommendation in Russia. Even in Russia, we have very great differences in radiological and medical resources between different regions. Moscow as a huge megapolis is on one side, and different regions in Siberia and Far East in the very different from Moscow. If we go to, if we talk about local resources, so it is not possible to say we do it or we not to do it regarding any obstruction. We need to talk about it, this point in the concrete region with concrete local medical resources first of all. And the second point, of course, why for screening for CT pattern of COVID pneumonia, viral pneumonia, for example, in patients with mild presentation or without any presentation. What is the aim of this? We know that such patients need to be isolated, but what they do after this isolation? We have a special treatment for this patient. The CT pattern will change this treatment. I suppose no. CT pattern may change treatment and triage of such patient only for patients who need hospitalization or need, for example, intensive care unit, but not for mild disease. It's my point of view. Thank you.
Thank you.
But also, sorry, but we have some interesting questions, couple of short questions.
Yes, Valentin, you're right. I see two questions, but one of the questions I cannot fully understand. That is, what is the duration of the control study for the mild lesion? And I think
I believe the question is, I wrote a commentary. I believe that is a question from Dr. Femina from Russia, question about need to follow up. So you found some mild GGO, the lung.
Okay.
How often and would you recommend to follow it up with CT, or maybe not? What's your opinion, Dr.
So, Professor Chen, do you have any recommendations or your ideas? How about your ideas for the follow-up for the patient with mild GGO? No, we cannot hear you because you are muted. Thank you.
Thank you. In my experience, if the patient have the GGOs, we will focus the patient in after 1 week. But in our hospitals, just for the GGO patient, we will isolate it in a layer, and then we use the portable X-ray for monitor the patients, because you know if the patient often come to the CT room, maybe they will separate the patient infected to another patients. So we use the X-ray for the monitoring the patients.
But it's mild GGO. Do you think the chest X-ray can be positive for this kind of patient? Or do you think the PCR, the nucleic acid test can be helpful?
You means the PCR is the positive?
No.
And the PCR is negative. I think if the PCR is positive, and then the CT we found GGO, the case is confirmed. So in our experience, if find the GGO, it will progress to the consolidation. Many cases will find in the X-ray. You can find consolidation in X-rays. Because I needed to say, if we use the X-ray to screen in just after the onset, maybe it's less 3 days, you cannot find anything. But if you find the GGO in CT, after 1 week, you can find consolidation in these patients. Seldom people is just have the GGO. Is it the answer?
Yes. I agree with you, and Juan Dan, and a very good question about lung CT. So again, of course we have our opinion, but maybe our dear Professor Chen will comment about need of lung CT for COVID pneumonia.
Professor Chen, can you?
Sorry, I could not got the main minutes. Sorry, could you speak again?
Lung MRI. Do you use lung MRI in COVID patients? Do you see any
MRI?
MRI, magnetic resonance.
MRI,
magnetic resonance imaging.
So is there a way, is there a function for MRI for the COVID-19 patient?
Sorry, we didn't use the MRI for the COVID-19. I think MRI is needed to, if for the chest, for the lungs, it needs maybe more than 20 minutes. It's very dangerous for use MRI to screen the COVID-19, because I seldom find any hospital is use MRI, because CT is very quickly, and X-ray is okay. Maybe in the Russia you use the MRI for scan the COVID-19 patient, the Dr. Valentins.
No, it was question not from me. We have the same opinion. because everybody knows that you can see different lung lesions, you can see pneumonia on MRI, but because of the equipment, clinic equipment, because it's more difficult for a patient to be inside the bore, because of the need for cleaning and so on and so forth, I see no ground. Only if someone does some, well, I don't know, scientific research, could be, but not for practical, use. Another story, sometimes you need to do, for example, brain MRI for COVID patient. In that case, it's the issue of the organization of the protection of staff personnel in the department and other patients in the department, but that's another story. And one short question, Juan Dan, please help me. There was a question from Natalia Ilina about children, question to young who. You see, please help me. Yeah? Question to young who from Natalia Ilina. Did you detect lung diseases? Yeah.
I think actually Professor Ho answered the question already. If you move to the answered question, and then you can see the answer from Professor Ho. It's a very long paragraph of sentences, and I think maybe the question is, did you have to differentiate these changes from other similar manifestations? I think it's really based on the clinical history of this pediatric patient. Because of this very special period of time, I think the very first thoughts when we see a positive findings in the CT image, we should come to COVID-19, especially this pediatric patient have the contact with other COVID-19 positive patient or family, history. And so because as far as we know that all the pediatric patients, most of those patients, they have a positive history for contact. And so based on this information, we could do the differential diagnosis, and we could put the COVID first place of differential diagnosis. Well, if the patient have no such kind of history, and the patient have some pre-existing systemic diseases, and then we should do the differential diagnosis then. And so I think, I hope this can answer your question. Well, and I'd like to say a little bit about the MR. MR is not only a problem of the scanning speed, but also a problem of the contamination, because MR room is very difficult for the, could be very difficult for the medical workers to clean it up once a COVID-19 patient came in. And also the cost for MR scan is very high. I mean, compared with CT, compared with X-ray. And also MR is not quite acceptable for the majority of the hospitals, because we are the top hospitals in the area, in the country. But think about all the hospitals, MR is not quite, a often tools, a quite common tools for all the doctors to get, to have. And so I think MR is not the first choice. Yeah, thank you. So I think there's no more question. And so Valentin, do you think we have more questions, or Dr. Turing and Professor Chen?
No, I've checked the questions, so no more questions, and already we are beyond our time limit, so probably, I would like to ask you to conclude. Thank you very much. Actually, you should conclude for this wonderful webinar. Pleasure. And again, I would like to say, many thanks to our Chinese colleagues, because your society have started this initiative. And for example, I was a participant, attendee of your recent meeting with the Italian Society of Radiology. So it was also very, very interesting, because our Italian colleagues, they have a lot of also interesting cases. And I believe that, you see, we had like over 140 participants. It's okay, and I believe that everybody benefited a lot. So everything what we learned, what we get from this webinar will be for sake of our patients, to better treat our patients. And I hope that we continue our very good communications and relationships, and maybe we will think about continues this, I would say, tradition, not only about COVID, but our societies can meet and exchange with our opinion about different topics of radiology. Thanks a lot. Have a nice day and be healthy. Thank you.
Thank you, Wellington. I think you're definitely right. We can do the collaboration, yes, in the future, not only COVID-19. And so due to the time limitation, our exchange program has come to the end today. We sincerely thanks all the speakers and the audience, especially Wellington, Professor. And so we hope this exchange program will help all of you by diagnosing, but not only diagnosing, but also protecting yourself and your stuff during this special period. And so, like Professor Jin said, though we are from different countries, we are all mankind and all radiology colleagues. It is our duty and pleasure to help each other. And so stay healthy and remain strong. Goodbye for today, and see you in the future. Bye-bye.
Thank you.
Bye-bye. Bye-bye.
Okay.
Thank you. Я еще продолжаю писать ответы. Спасибо.